All right. Hello, everybody, and welcome to the Excel in Your Future PT Career series. I think we're coming up on about a year of doing these, which is super exciting. For those of you that don't know who we are and what we're about each month when we meet, I'll go over that a little bit before we introduce our speaker today. We are Confluent Health. Confluent Health is a series of brands that really have come together to change healthcare and change the way that we provide PT, OT, speech language pathology, as well as some industrial health and education across the healthcare spectrum. Specifically in these Excel in Your PT Career series, we focus on your PT career as a student, what it might look like now as a student, and then moving into rotations, and then once you're out in the world. Each month, we bring in one of our specialists. Confluent Health is made up of over 600 clinics across the US, and we're unique in that over 63% of our PTs that qualify to be a specialist, so maybe an orthopedic specialist or a sports therapist specialist or geriatrics, over 63% of our qualified folks are actually specialists. In the world of PT, only 11% as a whole are actually specialists. So it's super cool, and we bring them to the forefront on these calls. Sometimes we go over things that are really clinical specific. Sometimes it's about interviewing and what your future career might look like specifically. Today, I'm really excited to introduce Dr. Liz Evans of Physical Therapy Central, PT Central in Oklahoma. Liz is an orthopedic specialist as well as a pelvic floor specialist. She is also a clinic director, so a leader and a manager within our company, and has been for many years. She's a specialist on many levels, and today she's specifically going to talk to you about pelvic health. So I'm going to pass it off to Liz to get you rolling.
Awesome, thank you. So do I share my screen for this? Okay.
Yes.
Thank you. Okay, let me do that real quick. Thank you to everyone who got on. I was afraid there'd be no one, and there's a lot of people, so. Okay. You guys see that?
Yes.
Okay.
Good to go.
Awesome. All right, so let me get slideshow view here. Okay. So, as Allison said, I have been treating in outpatient and in orthopedics and pelvic health for the last 10 years. I've been treating orthopedics for the last 17, pretty much now. Yeah, the end of May, 17 years. So I first went and got specialized in orthopedics. That was really my kind of love. And got my OCS, did an orthopedic residency. And then the Evidence in Motion, who I did that through, came out with a pelvic health certification, and I just decided to do that too. So I've been doing that for about 10 years now. My practice really is about 50-50 ortho pelvic health. That's by choice. We could certainly be full pelvic health, but I really love the ortho. I think it's the basis of everything. And really all my pelvic health are ortho, they're ortho patients. We just have a little bit extra stuff we know and do with them. So for some of you who are maybe I don't know about pelvic health, hopefully you'll kind of see how it can be very ortho based. And really there's a lot we can do, even if you're not certified in that area, with patients who may have some things going on with their pelvic floor. So I'll go ahead and start, but if you guys have any questions, are they able to, I can't really see anyone. So are they able to ask questions or unmute or anything?
So not able to unmute, but there
Okay.
is a Q&A feature. So if you have questions, you can navigate to that, and then we will monitor it and let you know if we have any questions for you.
Okay, perfect. Okay. So sorry, I'll change this back to slideshow. It's weird because I'm just talking to a PowerPoint, and it's freaking me out. Okay, because I can't see you guys. Okay, So here, the objectives that I'm going to go over today, we're just going to go over anatomy, physiology of the pelvic girdle, the prevalence of pelvic floor dysfunction, and kind of the purpose and function of the pelvic floor and how it's working with the core and the rest of the body. And then we'll kind of go over like how you would do an exam, even as an orthopedic therapist, for a patient who you suspect may have something going on in the pelvic floor. And then I'll kind of go over some basic treatment concepts. Okay. So pelvic health, I mean, I'm sure a lot of you guys know this. It's a specialized area of PT who helps people whose daily life is affected by pelvic dysfunction. So beyond whatever, may be going on in the lower quarter, the lumbopelvic area, we're also going to look at bowel function, bladder function, sexual function, kind of all the things that the pelvic floor helps support, along with lumbopelvic pain, hip pain, those kind of things. These are kind of common complaints that I end up seeing a lot in clinic. We certainly see a lot of urinary incontinence, a little bit of fecal incontinence sometimes, bladder dysfunction. So that, I mean, it doesn't always just have to be leaking. It could be an increased urinary urgency or increased frequency or decreased, either way, but just some sort of problem there or difficulty voiding. Constipation is really common, and you'll see this a lot along with low back pain or with patients who may be taking pain medication. So that is always something that you can ask about. Bladder pain, bladder conditions, spasm, pelvic organ prolapse, pain with intercourse. And then we see more like orthopedic presentation, like a tailbone pain, a coccyx pain, pudendal neuralgia presentation, pain with sitting. And then also looking at pregnancy, postpartum type of conditions. So I didn't even include on here pain during pregnancy or problems during pregnancy, but that certainly is a big area. And then certainly after delivering, postpartum, having abdominal separation or having pelvic floor problems because of their vaginal tearing or whatever occurred during delivery. So some risk factors that I kind of think about whenever I'm looking at a history are any like abdominal, GI, or genitourinary surgery. So, I mean, even if it's a laparoscopic, open, whatever, gallbladder, appendix, all of that I kind of want to know about because of the potential for scar tissue and guarding and stuff through abdomen. Certainly GI surgeries, and then like hysterectomy, any bladder surgery, like a bladder lift, C-section, any of that I want to know about. And then history of childbirth. I don't know that I would say history of childbirth. I mean, I guess it is a little bit of a risk factor. It is a kind of a trauma that happened to the muscle area. But certainly if it was vaginal delivery and it was forceps assisted or they had grade 3 or 4 tearing, then they are definitely at risk for issues later on. So really getting down into the nitty gritty and asking, did they tear? Was it, did they know how severe it was? Did they have forceps assistance? That all helps me kind of get an idea for their risk. Breathing disorders have been kind of correlated with lumbopelvic pain. And so history of asthma or history of COPD or, even just high anxiety breath holders, I would say kind of have a risk. So that's something to look at as well. Any history of low back, hip, pelvic pain, then, just even if you're just doing an orthopedic therapist, not a pelvic floor therapist, I think it should be in the back of your mind that there could be something underlying. And later we'll kind of talk about what subjective questions you would ask to kind of rule that in or out or help know if that might be present. And then increasing age is a risk factor, especially with women and hormone changes postmenopausal. So there's, for prevalence, It is estimated that around 22% of musculoskeletal diagnoses have some sort of pelvic floor pathology or pain going along with it. And then this second one, this 2018 study found that 95% of people who have a complaint of lumbopelvic pain did have some sort of muscle dysfunction identified with a internal digital pelvic floor exam. So that's pretty crazy. I would agree with that. I see that in the clinic all the time, but just it just points out that we need to make sure and realize that part of the core and lumbopelvic, region is the muscles of the pelvic floor, and we can't really ignore those totally. And then in women between ages of 35 and 74, up to 57% experience some sort of urinary incontinence. So I think it's kind of been a messaging around that this is kind of normal and very common, of course, but we know this is not normal. This should not be just kind of accepted. I don't think they end up reporting it a lot, so this may even be higher because who knows if they're even talking to their doctors about it. So, all right, so the anatomy of the pelvic girdle, the pelvic floor itself is down here at the bottom. Can you guys see, can they see my mouse? Can you guys?
I don't think so. Oh, we can? Oh, there it is.
Do you see it? Okay. Okay. I'll use it kind of as a pointer. But so right down here is the pelvic floor sling. It's kind of a muscular sling made up of three layers of muscles, a bunch of different muscles that are supporting the pelvic organs above it. And then up here, oops, sorry. It works with the transverse abdominis, the spinal stabilizer muscles, and then the diaphragm isn't shown in this picture, but the diaphragm up here, and that's kind of your closed core pressure system all working together. So the pelvic floor is a piece of that system, but we have to really consider that whole system. So the way that I learned it, we kind of broke it down into 3 layers. Layer 1 and 2 kind of make up this superficial urogenital triangle. So this is like a pelvic model just looking at from the bottom. So the urogenital triangle right here. And then the layer 2 kind of deep perineal muscles right here. So I just always tell patients, hey, these are your squeezer muscles. Their job is to kind of close and help with continence, but they're also, they really need to be able to open and relax so that you can let urine come out, or you can have intercourse, or do a deep squat, or whatever they need to do to kind of stretch. So a lot of times we think about the squeeze, but we also have to think about them relaxing and opening as well. And then third layer is the pelvic diaphragm. So this is looking down into the pelvis. And so this layer, these muscles, their job is more to provide the lift and support. These are more slow twitch muscles, so they're kind of more built for endurance and to work throughout the day. So you need both that kind of squeeze of the outer muscles and the lift of the inner muscles to really have a proper pelvic floor contraction, but you also need an opening and a drop to have a full range of motion of these muscles. So really that's kind of the take home. That open and drop is so important, and that's so much of the time where our patients are not able to do that. And that's also where you just don't prescribe Kegels always right away in PT. So we'll kind of talk more about that. And then you have all these deep glute muscles, the adductors, the piriformis, psoas. These are all muscles we kind of need to be paying attention to. So we don't want to just zero in right on pelvic floor. We've got to look at the whole kind of global system. So the job of the pelvic floor kind of sling is, or group is, it has five different purposes. And so in any patient, it may be doing some of these okay, but not the others. It may not be doing any of them okay. But depending on what it's not doing is how we decide how to format treatment. So certainly supporting the pelvic organs above it, but also providing a little bit of stability to the lumbar spine and pelvis. And stability doesn't mean stiffness necessarily or rigidity. It means they are working with those muscles above it to kind of respond to force coming through the trunk and respond appropriately, be able to move and stretch a little bit if they need to, and then respond back up, kind of like a trampoline would do. That's commonly what I'll tell patients, that we really need that pelvic floor to give and relax to whatever force is coming down and then respond appropriately back to stabilize. Sphincter control, we kind of already talked about those outer muscles, so maintaining continence. Sexual function, these muscles have to be able to get blood flow and have strength in order to really provide everything needed for proper sexual function. And then they also act as a sump pump to return venous and lymphatic fluid up the body. And so that's an important one, I think, that I didn't really think about before I ever got into this, but is a really important part of the lymphatic system. So I've kind of alluded to this a little bit, but pelvic floor dysfunction can involve many kind of different things. Certainly we think about weakness often because we're treating incontinence, but there can also be poor endurance. There can be excessive tension in the muscle, kind of shortened, really tight muscles, and even to the point where they're a little bit overactive or almost like spastic. And really, I would say in most of my patients, that's what I'm assessing and finding. These muscles tend to overwork a little bit and guard. And then, a muscle that's halfway contracted, like if my biceps is halfway contracted, I don't have a lot of strength left for a biceps curl. So, a lot of times the weakness, I think, is coming from that. It's not that they just have low tone, can't activate muscle. So there are patients that do just have low tone, and that's probably going to be the older, postmenopausal. Sometimes there's just patients that just don't, their brains are just not connecting. So, occasionally we will just get that straight weakness, but usually it's more the excessive tension, impaired coordination. So when there is impaired muscle contraction, the pelvic floor cannot engage, especially in a timely manner when it needs to. So whenever I'm taking a subjective history, these are kind of some things that I dive into a little bit more and ask. And these are all things you could ask any orthopedic patient, especially lower quarter. I'm not thinking about these in someone that maybe presents with shoulder pain, but if they're thoracic or down, then a lot of times I will, even if they've come for ortho, I will find myself end up asking a lot of these questions. So you can throw some of these in with your patients, really with any of them. So OB-GYN history, if you're working with women, we need to know, I didn't even put it on here, but surgical history for sure, gynecological surgical history, menstrual history, specifically if they are at menopause or postmenopause, then they're having some atrophy of the muscle probably. Those hormones just are not keeping those muscles super healthy, and so they can have more pain, they can have more weakness. But also with menstrual history, you may have, I would ask about pain during periods, because if they're having a ton of pain every month and doing a lot of guarding and fetal position or whatever, they probably have some increased muscle tone and spasm. And then we want to know if they have had any pregnancies and deliveries, the mode of delivery, so vaginal or cesarean. Was it assisted? Like I said earlier, if they assisted with forceps, then they're at a little bit increased risk of problems. And then tearing, same thing. If they were grade 1 or 2 tearing, they may have a little scar tissue, but not a big deal. But if they're grade 3 or 4, then they're probably going to have a little bit more dysfunction through there. Episiotomies have also been shown to increase risk of pelvic floor problems a little bit. So asking about that. They don't tend to do those every time now, but 20, 30, 40 years ago, they were doing them a lot. So in my patients who are around 60, a lot of them did have episiotomy. And then we want to know about pelvic pain. This could be abdominal, pelvic, lumbopelvic. I mean, we kind of want to know about all of that. This specifically is kind of talking about vaginal pelvic pain here. A lot of this talk is really, by the way, just kind of made for more of a women's health, but I see male patients too for pelvic. So if you have any questions at the end about that, we certainly can talk about it. Because we'd ask a little bit different questions about pelvic pain for men. But for vaginal pain, pain with intercourse, pain with inserting anything, finger, tampons, penis, we want to know. And we kind of want to know, is that at the start? Is that deeper? So you kind of have to get them to talk a little bit. Where are they feeling the pain? And then also if they do ever have like a feeling of pressure or something falling out. So we're thinking that would be a little bit different thought process because we're thinking a little bit more prolapse with that. But we want to ask about that. With male, I would say I want to ask about pain with erection, if they ever have that. If they have testicular pain, that's fairly common in the younger guys that come in for pelvic floor PT, or any like pudendal neuralgia type, so like perennial type pain with sitting are kind of some of the more common things we would see in male pelvic pain. Okay, so then I kind of break it down into like bladder function, bowel function. So for bladder function, we want to know how much they're going, how many times they're voiding during the day and at night. It's normal to go about 6 to 8 times a day, which is every 2 to 4 hours, and up to 1 time at night. So that can kind of give you, because a lot of times they don't know. And so I say, well, can you wait 2 hours before you void? A lot of patients with higher pelvic tone can't, and they're going every 30 minutes or every hour. But then you also may have the opposite of that, and you may have like a nurse or a teacher who just can't get to the bathroom and they're holding it all day long. So either way, it's not normal, and we need to kind of correct that. But first we have to know where they are. And I would probably also add to this, are they able to empty fully? Like, do they feel like they're emptying their bladder all the way efficiently, getting it all out? And then we want to know if they have any leaking. Leaking, like I said earlier, is not normal. So even if it's just a dribble, we want to know. And is this more with like laughing, sneezing, exercise? That would be more of like a stress incontinence. Or is this more of like an urinary or urge incontinence? Like they get the urge and they just can't, their brain and bladder just cannot figure out how to stop that until they get to the bathroom. Okay, for bowel history, I want to know number of bowel movements. This says per day, but also some people don't have them every day, so per week. Frequency can give you an idea about constipation, but patients can also be constipated and still having a bowel movement every day. So we also want to know what the stool is formed like, kind of what does it look like? Is it really hard? Is it really runny? Do they have pain when they're having a bowel movement? Do they feel like they're having to strain every time? So those, even if they are going every day, but they're having really hard, painful bowel movements and having to strain, then we're probably thinking constipation. Certainly if they're going less than 3 times a week, then I'm thinking that as well. And then also, do they ever have any fecal leaking, which they could also have with constipation. Sometimes they're so backed up that only the runny stuff can get by. And so, it doesn't always mean they're just weak. You kind of have to figure it out. Surgical history, we kind of already talked about. Hip surgeries I did throw in there just because I do see a lot of pelvic floor problems with labral problems in the hip. So if they either have a labral tear or hip impingement or have had a labral repair, then usually I want to think about pelvic floor too. And then sexual function, so pain at all with intercourse or sexual function, even external stimulation is not normal with erection. So want to ask questions about that. And really, they should be able, if the muscles are doing their job fully, they should be able to achieve orgasm without pain. And so that's something to ask about as well. So moving into kind of how I maybe would structure an exam with the patient, I would certainly, most of the time, I am doing an internal exam with these patients to assess pelvic floor. So I have that whole, that toolbox. I didn't totally go over that in this PowerPoint. I'm more going over kind of how you would do that if you were not doing an internal exam. My choice is to do the internal exam if the patient is consents to that and understands that fully, just because I can get a better idea. But I do usually try to save time for all of these other things as well, or as much of it as I can, or maybe second visit, we're going to do kind of more of an orthopedic exam, because it is all very important to see the whole picture. So for a standing exam, just looking at posture. This is nothing, you guys are learning this in school. This will become very normal for you for any exam that's a lower quarter exam. I do the single leg stance almost with all of these patients. Even if I am focusing mostly on internal, I usually throw this in there because you can get a lot of information from single leg stance, I think. Especially if they have any weakness in those lateral hip muscles. Side view, let's see, just forward and backward bend, looking where motion comes from. And then I usually try to throw in a squat, because again, just like the single leg stance, you get bang for your buck on what you're able to observe. And remember, at this point, we're just collecting, I'm not trying to make a diagnosis off their squat, but I'm just collecting information to help me with their diagnosis later on. So this is where I get a little more specific on like what I want to see in a patient who I think has some pelvic dysfunction going on. I use the posterior shear test a lot. I do really feel like SI dysfunction is a thing, and I feel like I see it quite a bit in clinic. I do seem to see it more in women, but I definitely think that it can be a pain, an area causing pain. So this posterior shear is kind of part of, you guys probably learned about the Laslitz algorithm in school. I kind of take this test from that because I clinically feel that I can usually see if there's any pain coming from there. If it's painful at all, I'm not going to rule out SI dysfunction. With this test, they're just supine. My hand, the base of my hand is right under the sacrum. And then I'm going to shear down through the femur on one side to kind of shear that SI joint on that side and see if there is any pain provocation with that. That's really the only thing I'm looking for is pain response. I also really like this active straight leg raise. And I don't think I learned this in school. I think I learned this later on. But it's a test to kind of see how they are transferring load through the trunk and pelvis. So I have them supine and ask them to raise each leg about 6 inches off the table. And if they have increased heaviness with one leg or the other, then I apply pressure just right across the pelvis in the ASIS on each side, kind of a compression. And then I have them repeat and see if it changes. So if they have decreased heaviness or it's easier to lift, then it's positive test. We just provided some compression and stability. and they were able to transfer that load better. So kind of helps you. I think that test is really great for buy-in for the patient. And then also, you'll want to throw in some stability exercises. And then kind of your Faber test. I really like Faber test kind of more as a test retest. Again, if you can do the Faber and they're really tight and you do some mobilizations to that hip and you improve it, it's really good buy-in for them kind of buying into PT. Hip range of motion, hamstring range of motion, you can do some palpation all in supine. And then I go into abdominal palpation. I think this is something we as PTs as a whole just kind of miss this area, and you can get so much work done here with lumbopelvic patients. So palpating through rectus abdominis, seeing if there are any trigger points along those muscles. Iliac is psoas. You can even kind of get up into the diaphragm and palpate there and see if there's any pain or tension noted. Also, with abdominal palpation, if they have any incisional history, scar history, you can palpate along those scars just like you would for any other area of the body. While they're here, you can see if they can engage transverse abdominis. I try to not cue them very much. I just say, hey, tighten those deep abdominal muscles, and I'm just observing to see what they can do. Often they're going to Valsalva, or they're going to kind of strain or use rectus abdominis. So then you have something you can treat already. And then diastasis recti is what can happen during pregnancy when the rectus abdominis muscle kind of separates right at the middle. A degree of this is kind of normal. I mean, you need some separation for pregnancy, but tearing of it is not normal. And so if there is tearing, they'll have kind of a separation. You also will see this in older men with bellies. I see this a lot in them. So it doesn't always have to be post-pregnancy, but to assess for this, they're supine. You just place fingers horizontally right at the umbilicus and ask the patient to lift their head. And you're just palpating the edge of the rectus abdominis muscles. And this is very easy to feel if it's positive. So 1 finger width separation is normal, but 2 finger width or more is kind of where you would grade it. And I would really pay attention to depth. If they're 2 or 3 fingers, but I don't really fall in, then I'm not as worried. But if you're falling way into their abdomen, then they've got some more significant tearing. Side lying, nothing crazy here, just your normal palpating. A lot of tension I find in piriformis and glute muscles in these patients, and a lot of glute med weakness, just like we see with all hip and back patients. So you can go ahead and check these things while they're side lying. And then, like I said, I would prefer an internal palpation of pelvic floor muscles. Certainly, again, informed consent. I always show them a pelvic model. I show them the muscles and what they do. Why do we need to get in there and assess them? So informed consent for internal or external, because even with external palpation, you're kind of getting a little bit invasive. So educating them first is always super helpful. And documenting that you had informed consent for assessment. So but you can do this externally. You can have them supine or side lying for this. If you are able to get a glove on and get right on the skin, I think it's really helpful to feel. But if they have thin leggings or shorts or something, you can always just do it over their shorts, especially first visit when they're not really used to you. So the goals for palpating externally are to kind of find the bony landmarks, and then some of the soft tissue structures. So kind of getting on some of the pelvic floor that maybe we can feel a little bit externally. Palpate for muscle activation, and then also palpate for tension or pain. And then you can also just observe the perineum and just kind of see if there's any movement there when they activate the muscle. So a Kegel is the pelvic floor muscle contraction that we're assessing. And remember, we're assessing, can they activate it and can they relax it and let it go? So do a full range of motion. So cues for this, I usually start with, like you're trying to cut off the flow of urine. That usually works pretty well for female patients. For males, sometimes you have to say something like think about drawing the testicles up toward the body. Their muscles are oriented just a little differently. So you just have to play around with cues to help them figure this out. So, like I said, side lying or supine. And if they're supine, I would have their knee kind of up and hook lying. But you can palpate along the sacrotuberous ligament. Really, there we're just palpating for pain response, I think. Adductor muscle. The adductor muscle tends to mirror the pelvic floor. So if there's tension and pain with palpation along adductor, you can kind of assume that there's probably some pelvic floor tension as well. So that's helpful to kind of follow that right up to its attachment. Again, you have kind of gotten informed consent and they know what you're doing. For levator ani, which is kind of the main muscle of that deep layer of the pelvic floor, if they are, let's see, either way, if they're supine or side lying, I try to find the ischial tuberosity and just come just medial to that. And if I let my fingers kind of just fall medial to that ischial tuberosity, then you fall kind of onto general area of the pelvic floor. And you can assess for tenderness, you can have them do a Kegel contraction, see if you feel a little bit of bulk kind of come into that muscle. And then you can have them relax and see if they're able to do that. You also can assess like quick flick contractions, kind of see how's efficiency of fast twitch muscles. And then you could have them do like a 10-second hold to look at endurance as well. So you can do a lot of that just externally and get a lot of idea of what's going on. Obturator internus, I think in side lying, this is a little bit easier, but you can kind of move your forearm more perpendicular to the table and kind of angle toward the acetabulum and get on that obturator internus. There's often a lot of tenderness with this muscle. It tends to be kind of overly tight. If you are unsure if you're on it, you can have them resist external rotation of the leg you're palpating, kind of have them push that knee into the table. So I usually am palpating the side that they're lying on. And you should kind of feel that muscle pop up. So after you've kind of looked at these different things, you're gonna, we're coming up with a PT diagnosis. Now, caveat here is they probably will have some sort of like hip mobility problem. It's a puzzle. So this slide is just talking about kind of pelvic floor, but knowing also there's some hip mobility problems on the left, there's a weak glute med on the right or whatever. You're going to throw those into your treatment too. But as far as pelvic floor diagnoses, I kind of just simplify it into overactive or underactive, and then probably a mix of both for most patients. But most of mine, again, are in that overactive category. They're a little bit higher tone. They have some pain, maybe have difficulty voiding, constipation. That's going to be more common. They can still have leaking though, because those muscles just are not able to engage timing correctly to help counteract pressure. And so the bladder will leak. These overactive patients often have pain with intercourse. A lot of times they will have some hip or low back pain. And they're usually, younger, what I see most often in clinic. The weakness underactive patients, they're going to have more of the incontinence and probably maybe some prolapse symptoms. They will have low tone and usually not a lot of pain. They usually don't have a pain complaint. And difficulty with activation. You won't, you really just won't be able to feel those muscles do anything at all. So then we are, deciding what we're going to do for treatment. So manual therapy techniques that I kind of include with, I really do a lot of these with all of my pelvic patients. We can't always do it in one visit, but that's the beauty of PT, I think, is that we have multiple visits and we can, prioritize each visit what you're going to work on, but there's lots that can be worked on. So I didn't even put this on this slide, but internally we can do work. We can, if you get into pelvic treatment and certified and start treating that, then you have a whole nother manual therapy tool to do internal myofascial work, release, and like feedback work on doing some neuromotor reeducation. Externally, all of these things. So abdominal work, I think, can be huge. This is usually where I start with male pelvic pain or male pelvic patients because we can get so much done abdominally. Because there's usually a lot of tension, they just usually are not even connected to that area of the body. So even just palpating to get the brain to connect, I think, can be helpful. I use lumbopelvic manipulation a lot with, especially if they're presenting with some SI area pain. Again, this is like a efficient bang for your buck treatment that you can do and then still have plenty of time for some other things. I do a lot of hip mobilizations and a lot of mobility stuff with the hips, and then turn that into strengthening once they get that range of motion. Indirect muscle release, this can be done manually. This can be done dry needling. I do really like dry needling with these patients. Even cupping sometimes, just whatever you can do to get the muscles that need to be released, knowing that then you need to stabilize and strengthen them in their new range of motion. And then looking just at thoracic spine too with these patients. For neuroreeducation, so this is where I would say almost none of my patients get Kegels day one. Almost all of them get diaphragm breathing prescribed day one because the diaphragm muscle is up, it's up. I don't know if you guys can see me, but it's up under the rib cage, and then the pelvic floor is down here. And the diaphragm and the pelvic floor work like a piston pump. So if the diaphragm is not engaged, if they're not using it, which most of us are not often, then the pelvic floor really is not getting full mobility and use. This is a little confusing because we tend to think like take a deep breath and tighten everything in. But when you're using diaphragm breathing properly, when you inhale, the diaphragm is contracting down and the pelvic floor muscles should relax down. So sometimes it can take, 3 PT sessions to really teach that, but it's so important to do that to form the basis of their care where you build everything else on. When they exhale, diaphragm recoils back up, those pelvic floor muscles and the transverse abdominis engage much better. So that can really be used with exercise training once you're to the stability and strengthening phase. And then thinking about not only strength and activation, but endurance and timing. So if they're leaking when they sneeze every time or cough, then I might prescribe them a Kegel cough exercise where they are retraining that Kegel first, then you cough, Kegel first, then you cough. If they're leaking, sit to stand is a common, like post prostatectomy. Almost all the male patients I see will leak when they do a sit to stand. Then you can work on that timing. Kegel, exhale, and stand up. Kegel, exhale, stand up. So hopefully that kind of makes sense, but you can do this a million different ways. It's kind of really fun to be creative and figure this out with patients. This slide is just very common exercises that I prescribe. Usually we start more in the stretching and I call it down training, kind of down training, breathing, yoga type stuff. And then once they can do all of that well and can use the muscles in full mobility and range of motion, we can start working on the strengthening, which gets really fun. I do think you can strengthen hip, transverse abdominis, those kind of things right away. So it's not that we're doing nothing, we're just probably not doing Kegels right away. So that's kind of like in Therax, Theractivity, manual therapy areas of treatment, but patient education is huge with this population as well. And this, again, you don't have to be a pelvic therapist specifically for a lot of this. So like with bladder, behavioral modifications can be, I mean, really, sometimes these can just totally change their life because they just don't know. So I'm going to actually do the second bullet point first. You may just need to have them do like a food and voiding diary because they may, if they're peeing every 30 minutes all day long, then I probably want to know this because are they drinking like 6 cups of coffee? If they are, that's an easy thing we can change. So a lot of times I'll have them do just 3 days for me just to kind of get a baseline. And to kind of, for them to kind of see triggers and patterns. And then we could go back up to the first bullet point and actually work on scheduled voiding. So if they're going every 42 minutes on their diary, then we're going to start kind of trying to defer that 10 minutes or 5 minutes to kind of retrain the brain bladder connection, retrain the muscles. If those pelvic floor muscles are doing their job, they're not allowing that bladder muscle to contract and void until it's ready. So I'm working on that. And then the opposite of that, if they're going 6 hours before a bathroom break, then we need to set a timer and start getting them to go at a more normal frequency. And then we kind of already talked about functional Kegels, but Kegels, static Kegels are not super helpful. These muscles need to learn how to do timing correctly, when to contract, when to relax. And so just working with function. So we talked about the diaries. You can also just give them a list of bladder irritants. And so they can then do the diary and kind of start to make connections on what may be irritating their bladder a little bit. It may not be all muscular. Um, and and really with bowel and bladder, water intake needs to be a priority. A lot of the patients that are leaking are going to decrease their water intake, but then if they're still having other things, their bladder's really irritated. So educating them there. And then fiber. I don't do a ton of this with patients, but at least knowing that they need to get between 30 and 35 grams a day, because I think most adults are getting about half of that. So just that one little tidbit of education may be helpful. And also, the fiber we already talked about, but also using a squatty potty is a really easy patient education that can be life-changing. When they're in this position, the muscle that goes back around, slings around the rectum is on a more laxed position. So it's almost like you're unkinking that rectum a little bit and it's just easier to pass. And then again, water intake for stool health, and then aerobic exercise just for gut motility. So, I just kind of wanted to do a summary, kind of recognize that pelvic floor dysfunction is very likely present in a lot of our patients we're seeing every day. And I think I hit this pretty hard, but Kegels are not the answer most of the time, a lot of the time, and probably not where we should start. You need good mobility in the pelvic floor so that it can actually work. And you just have to look at the whole picture. Looking at above and below, regional interdependence is just so important. Yeah, and I think that is the end. So definitely open for any questions, talk about anything you guys want to. And I'll stop sharing.
All right. So if you all have any questions, thoughts, either related specifically to the content Liz just went over, or even what's it like to be treating pelvic floor and ortho and in that setting and to be a PT doing those things, sort of nothing's off the table. So feel free at the top, you'll see a Q&A button. You can enter that. You can be totally anonymous. You don't even have to tell us who you are. So we'll give you just a minute to type any questions you have in. And we'll also remind you that if you don't want to ask a question now, but maybe you have a question that you'd like to ask offline, we'll make sure that you all have a follow-up email with our email address in it. So you can reach out at any point if you have specific questions, either for Liz or for us at Confluent about rotations or potential jobs, that sort of thing. All right. It does not look like we have any questions. Emily, do you see anything on your end before I close this out here?
Nothing on my end over here.
Okay, awesome. Thank you. I just want to give another shout out to Liz for being here. It is so wildly important that this population gets treatment. It's really rare to find a community that has a robust pelvic floor community that can treat and support through these things. And like Liz said, a lot of patients just think this is something I have to deal with for the rest of my life. So I'm going to just not tell anybody and keep going and kind of silently suffer through it. And there's really no need for that. A lot of the things that people don't bring up are actually very, very treatable and very treatable by PTs. So that's pretty cool. It looks like we do have one Q&A that came in real quick. So how do you handle discussing internal exams with patients who are a little bit more apprehensive about it? And Liz, I'll pass it to you for that.
Okay, thanks. Yeah, it's funny because you can always tell when a referral source has not prepared them. But I always, I ask all these questions that I talked about in the subjective. So I think they're kind of getting an idea of what they're getting into with my questioning. I try to be real, as PTs, I think we just have to remember that we're a person and they're a person. And just have a conversation, be super chill. I try to bring some humor into it. You just can't be like super rigid or else they're gonna follow your lead. But I always show them the pelvic model first. So having that pelvic model is really important and kind of point out the muscles and what do these muscles do. And then that's when I just say, typically to examine or to evaluate these muscles, it's much better if we're able to do a pelvic exam. I'll say it could be a vaginal exam. With males, it's going to be a rectal exam, which is a whole nother. They are often like, what? So I don't typically do that with males on first visit, but I will tell them about it. And I say it's a tool we have. It is 100% up to you. We can assess things externally. We can visit that when you're comfortable. But showing them the model, getting them comfortable, getting to know them, I usually feel like with rapport, we get there easy. Even if they kind of laugh about it because they did not know that's what they were getting into. Always, always their choice. And if I'm ever like sensing like they're saying yes, but their body is saying no, then I just make the choice for them to not do that day. You'll know when they are ready for that.
Totally. Thanks, Liz.
Mhm.
All right. Good deal. Well, thank you, everybody. Again, reach out if you have any questions. If you're interested in doing a rotation specifically in pelvic floor and ortho, we can also get you hooked up with the right folks across Confluent, whether you're in Oklahoma or somewhere else. We can probably find you a spot. Same thing, if you're interested in a job related to that and training specifically, we can talk to you about that as well. We hope that you all join us next month. We will have another Excel in Your PT Career series. We'll be releasing the information about that shortly. And thanks for spending your evening with us, guys. See ya.
Thank you.